Hey, Rich, good morning. I know you had a busy week. Tell us a little bit about your experience this week and really dealing with your airway issues.
Right. Well, good morning, Mark. As you know, I suffer from significant airway issues, and we can get into that a little bit more if we have time. But basically, I had a 2 day sleep study that was conducted recently. I went through the entire process, and I learned a lot in terms of what the patient goes through, and I really felt well cared for in this particular place that I went to, and I have a lot of things I could share, and it kind of got me thinking about the patient experience. The patient experience of going through the whole airway process from showing up at the dental office with a complaint that has nothing to do with airway in their mind, but actually has everything to do with airway. And then how does a provider of this kind of care transition from, let's just say, the fractured distal lingual cusp on tooth number 18 to something that is more relevant to their true medical concerns or medical condition, if you will? How do you transition from that patient with recession on all of their teeth and sensitivity, and you know darn well this has to do with growth related issues, and it has overlaying symptoms of and signs of airway issues. How do you transition from that into the greater cause, the mission that we share? I mean, and I think this is a tough one. And even though we graduate from the airway mini residency and we have a lot of knowledge and understand really a lot of what's going on, this is a skill set that takes a little bit of time to develop to do this particular transition. So I just thought I would throw that up there as a topic of discussion, and I'm happy to chime in at any time
Sure.
with specifics about my own experience.
Yeah, I think that's really excellent. And what I've really heard through the years in going through the mini residency that the participant, the provider that's sitting in the audience finally goes, aha, I get it. And you know what happens is you're getting a lot of information. And it's kind of like going to dental school and you're going through histology and physiology and you're going through all the basic science stuff and you're going, when are we to get to cutting teeth or cutting tissue, right? It's like, what
Yeah,
does this have to do with it? Or if you're undergraduate, right?
right.
You're trying to get a rounded education, but you're pre-med and you've got to go through humanities and basic English composition and philosophy and all that. And you go, well, what does that have to do with me being a doctor, right?
Right.
And so clearly, that's all put together when you're dealing with another human being and relating in a specific context. You need that general education. Well, the airway, it's the same thing, but I think it's even more honed. And we always go through this exercise, usually in session three in the old format, where we call it verbal skills,
Right.
where we have the different providers that would, stand up and say, okay, here's your patient, here's the situation, how would you discuss it? That also leads into the elevator speech. How can you distill down if you're stuck in an elevator and you've got 30 to 40 seconds what airway is all about? If you don't go through that exercise, you're not really understanding. So I think going through and being able to condense a rather complex concept into understandable bite size that is meaningful to the patient is really an important way of answering these questions that the patient says, I came in for my cracked tooth and now you're talking to me about my sleep. You can't make that leap. So I think it's incumbent on the provider to understand it. And how do you do that? I think it's to a great extent having a rather deep understanding of the problem versus like a weekend course in learning how to titrate an appliance, right?
Right.
And so I think that's the conundrum that the provider has. It's pivoting from general mechanical practice into more of a physiologic mindset. And so that's where we go through that in the Airway mini residency. And I went through this obviously through the years. And what I've learned, because people will say, well, gosh, it just rolls off your tongue and it's just like it's your second nature in the way you talk about it. But that didn't happen overnight. It's really having this deeper understanding. And a lot of it has come from treating so many patients that I learned so much about to distill it down to these phrases, if you will, that are meaningful. And that's basically a lot of what we teach is basically the screening questions that allows the patient to connect the dots to where they really get it and they're motivated. And what we found is when you talk to those patients, they have the aha moment. Oftentimes, as you know, they start crying and breaking down. They go, I knew it, I knew it. It's just no one talked to me about it. I knew that it was related. Now, we know what's the exception when you're treating family and friends, because they'll go, oh, yeah, yeah, it has nothing to do with that. Just, stick to being a dentist, right? I mean, we can
Right.
laugh about that.
Exactly.
Like the old saying is, no one listened to Jesus in Nazareth, right?
Right.
It's like the prophet was never listened to in his own town. I mean, how could he know or she know? So I think that's a really good topic. So with that said, tell us a little bit about what your thoughts are going through as understanding that, but now being in the driver's seat as the patient.
Right. Well, for just to let everyone know, I have been suffering from fatigue for I would say well over a decade. Probably, if I can think back, it's been an ongoing problem. I sort of just thought, well, that's just the way it is. I'm busy. I'm tired because I'm supposed to be tired. Uh, I'm athletic, and I worked out. I did all the things I'm supposed to be doing, but man, I could not make it through life without coffee. And I'm the platinum Starbucks card carrying member. And I started to think about this is serious. I'm suffering, and and I don't know if you remember this, but it was about 12, 13, 14 years ago when I started to really open up to the possibility that airway was something that dentistry should be taking a very close look at. And I kind of self diagnosed and I put myself into the medical system while I was in academics and full time academics at that time. I put myself in the medical system to get a solution to the problem. And here they see this guy walk in with that doesn't have the physical characteristics of their typical sleep and problem patient. And I had to push the system to get me to the sleep study. I really did. I had to almost exaggerate my symptoms because their surveys didn't even ask about some of the symptoms I had, which I thought was interesting too. We know a much better way to ask questions, and much more thorough today than the medical, and maybe that hasn't even changed that much in the medical profession. But the point is, I eventually got to a sleep study, and then the results of that study were, no problem. But when I looked at the data from it, just on its face, I was desatting a lot. I had desaturations that were occurring quite a lot. And they said you didn't really meet the target for any intervention, but I insisted. So finally, I got myself onto a CPAP. And this was all motivated by my own desire to solve this problem. Well, as it goes, I didn't have a very good experience with the CPAP. This is in the early days of CPAPs, and I didn't feel that I was getting really good support. There were titration issues, etc. It was uncomfortable, I thought. I just didn't know what I didn't know. And so I basically blew it off and stopped using it. But then I started to notice the symptoms came back. I was so fatigued. I had other issues. And so I said, well, I'll just make myself an appliance. This is what dentists do sometimes. We try to treat ourselves. And so I made myself a mandibular advancement appliance, and I started wearing that. And then I didn't like it, and I got a different one and then a different one, and I must have had about six of them over the years. Um, and once again, no one overseeing my care. and I, and you know, it, ultimately I came to the conclusion I need to be a patient. I need to be okay with having someone else take a look at me objectively, gather all the data, and do it right. And that's when I came to you. So I finally got that experience of going through what it really meant to have all of those issues looked at in a much more, you know, I don't want to say professional, but I want to say targeted, intelligent, thoughtful manner, gathering all the metrics that were required to address me once and for all. Okay.
Okay, so with that said, let me ask you a couple questions. I'll jump in. Would you say that you was your chief complaint sleepiness or fatigue?
Oh, a little bit of both. A little bit of both. And right. I mean, so sleepiness for me is I'll just, if you could just sit there at an airport and put your head down to your chin, you fall asleep. That wasn't really the major issue for me. It was more just, gosh, I just feel like I don't have the energy that I should have. I
Fatigue,
need that cup of coffee, you know?
right. So if you didn't have coffee or energy drinks or tea or whatever your caffeine of choice is, um, what would your day be like? I mean, would you be able to get through the day?
Barely. I would power through,
Okay.
and it,
So that's the problem. I think, it's like you were saying, your phenotype is not the classic. And yet, I will argue that it's the base of that iceberg below the body, the water line. Although you're transitioning a little bit from the tip of the iceberg, which is the frank OSA patient, you've actually come from below the waterline where you've had this for years with non-hypoxic events. And now, because of the vibratory and reflux chemical exposure to the oropharyngeal mechanoreceptors that are now not working quite as well, you're now above the more above the waterline where you're more like a frank OSA patient now. And yet your phenotype doesn't match. And here you are, almost circling the drain. Tell us a little bit about any aha moments you may have had where you just explained what your experience was, having a sense of what may be going on. Because although you're an academician and in this, and you understand and you're treating yourself, think of all those patients that don't have the wherewithal or are actually searching by Google, right? And trying to solve their problem, which we
right.
know that there are a lot of patients like that. Tell us a little bit about the difference of now understanding airway more, that aha moment that made a difference now to really understand the problem better than say 10 years ago when you were first seeking that consultation with the sleep physician. Tell us a little bit about that. What was the
Okay.
difference now?
Right. Well, first of all, I, I didn't know that there was a structural solution to this issue. I had no idea. I basically thought, you're going to be tied to an appliance or a CPAP. That was the only intervention that was possible. Um, I learned that that is completely not the case. That there are many ways to address my condition. It's multifactorial. It involves a healthcare team. It involves very thorough diagnosis and investigation, assessment, if you will. So it's not just about snoring and apneas. It's a lot of other things. There's a functional component, there's a structural component, and there's a behavioral component. And I've really been enlightened into understanding that it's really that triad of things that you need to take a look at. It's just not one thing. In other words, you don't just fix me with a thing.
Right.
That's not the solution for me.
Exactly.
And I think that all of us naturally as humans are looking for that solution because why not? I mean, we're so great. We make all these things, and we make iPhones or whatever cell phones we make, and they're incredible. Why not in medicine or in dentistry? There should be a thing to fix me, and it's not that simple. But
Let me
it's
jump in and,
yeah,
and comment on that, Rich, because what you said is so important to understand is that we are all in our society in the West conditioned to expect a silver bullet solution to complex problems, whether
right,
it's a pill, a device, a surgery. And so I think that's really a key concept to
100%.
understand that there's a difference between being well and not being sick. We're conditioned to not be sick.
Hmm.
So we are conditioned to address symptoms in isolation, the anxiety, the irritable bowel syndrome, the reflux, the cognitive issues, and we go down a lot of different uh, siloed rabbit holes, if you will. And what I'm hearing from you is that you understand that really there's more that's going on there, structure, function, behavior. And beyond that, you also understand that there are opportunities to go beyond management. So the gold standard management approach in allopathic healthcare, in medicine, in sleep medicine, is to manage it by pneumatically stenting the airway open or mechanically holding the tongue from obstructing and dropping back during sleep. But it doesn't do anything about the root cause and the breathing during the day, and it only manages the problem. It doesn't cure that flow limitation, which is why the dental profession is really needs to understand our role in addressing the facial skeleton that determines those kinks in the hose, if you will, right? That's, from the tongue to the nose and down. So I just want to jump in because you kind of like it just rolls off your tongue that this is just what we're conditioned. Let's give me the
Absolutely.
magic pill,
Yeah.
and people don't want that, and it is a challenging to talk to a patient about it. Now, just end this piece here, because then I want you to continue, is like, how many times have we seen patients where we start talking to them and asking the right questions and letting them tell their experience, where when we respond to them, they start crying and become very emotional and saying, I now understand. I was treating all these things in isolation. I now understand how it's connected. And they become very emotional, saying, I knew it. Yes, I wanted the fix, but now I know I can get rid of all that list of pills and that device that's really bothering me now. And now I can understand that there's a cure potentially, right?
Absolutely.
And so I think that's the big challenge that we have as providers. And you're saying it, being a patient. So I think that's
Absolutely.
powerful.
Absolutely, Mark. And it is deeply meaningful to me, and it's very emotional because it, when you're facing a life of, I don't want to make it too gloomy, but there's it's a form of misery. Really, it's this chronic misery, and you start to just you 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 look at life as like, well, this is just the way it is. And this is how I'm going to suffer, and stop complaining about it. No one wants to hear about your complaints anymore. Even to the point where if I went into a medical doctor and they asked me, how are you doing? I go, I'm great.
Right.
Because you don't even want to share this information because nothing can be done about it.
Or you
So,
don't know what to share. Because in your mind, you're saying it has nothing to do with my appointment with this doc who's
correct.
looking at my blood pressure or talking to me about, depression or whatever, or my irritable bowel syndrome, depending. You haven't connected the dots. Why
Right.
would you bring it up?
Exactly.
Why would you bring up to the gastroenterologist that you have all this erosion dental, that your dentist said you have all this dental erosion?
Right. Right.
He probably wouldn't even look in the mouth.
Well,
He's going to do
true.
something that the dentist does.
Right.
And he looks at his siloed area, right? He's going to do an
True.
endoscopy
True.
and or colonoscopy and not even connect those dots, right? So it's everybody has that problem, right?
So interesting. Yeah. I feel very differently now, though, having been educated and enlightened as a provider, but also as a patient, that I see a pathway to a better life. And for me, it's huge. It's huge. I just now got emotional because it's
Gives you hope.
there's hope, and it really for us in I mean, you know, to have a solution to a problem that has affected you so deeply and so chronically is it's an unreal experience. And I can totally relate now to how our patients feel. And you've treated so many patients, and you've seen this time and time again, that it's a life changing, incredible thing to be part of, Mark. And as dentists, it is amazing. It is simply incredible that we can elevate our practice model, expand our practice model to be able to address these issues with so many of our patients that are suffering that will never tell us unless we ask the right questions.
Unless we're trained. I'm going to say, underscore, it's not in lieu of what we do as dentists. It's in addition to.
Absolutely.
It's a way of looking at the problem. And when you understand what you understand, I went through this aha moment, probably it was about 15 years ago, where my practice was limited solely to adults, doing complex perio-pros type of cases, full mouth rehab, occlusion, and restorative. And the light bulb went on for me personally with my then son, 4-year-old, 5-year-old son, where I connected the dots of where it starts. So as a dad, when you understand what's going on and could go back in time and say, when I look at myself as a kid, I was a stomach sleeper, I was a mouth breather, I drooled, I struggled here or whatever. I'm not saying you per se, but then you start understanding the concepts of craniofacial growth and development. Then you have to be committed to really looking at early or addressing early intervention and taking care of our kiddos, because those kiddos 20 years down the line are you, an entire population
Right.
of patients. It's just the next generation of CPAP wearers. And if we have a place in dentistry to really address that by early intervention, even if you don't want to deal with the pediatric population, I think you'd be compelled to add to your team those individuals that would be willing to.
Absolutely.
And then of course, if you're treating that population and you don't treat adults, you'll understand that the parents will oftentimes, when you start asking them, say, well, that was me. Doc, I'm next. So that's kind of the one thing about this Airway timeline, is that where we jump into the book, if you will, chapter 6 of a 14 chapter book, you could kind of see where you are and understand that you are in chapter 6. It's not the whole story. And where you are now, and maybe what makes it a little bit emotional, what I've noticed is that the patients, when they're jumping in chapter 10, they realize I should have had this dealt with and off of my Adderall and Ritalin in chapter 3. And I don't want that going on for my kids. And then they become very emotional. And all these, they start thinking about what if. Now, we know it's not always everything, but it's a big part of it that's being met and not being understood. So, yeah, that's interesting. It's not until you go through it yourself that you could
Yeah.
really see.
Yeah, and it's really interesting you point out the what was I like at a younger version of myself, and I checked all the boxes on a pediatric questionnaire. I mean, everything was there. I was an ADHD kid, but they didn't have the diagnosis back then. I was just
Quote
hyperactive.
unquote ADHD, quote
Yeah,
unquote.
quote
Yeah.
unquote. Right, right. I always was getting sent to the principal's office. I was my reports. The parent teacher conferences were always the same. Bright kid, acts out, can't sit still. Um, and then I was bedwetting, up to like age 9, and you just go through all of that history. It's like, my gosh, that was exactly me. But I was also an athlete. I was a competitive swimmer, and so I powered through. But I just remember kind of dragging and feeling tired, but no one wanted to listen to it. It was back.
It was a personality trait, right? It's
Right,
because
yeah.
this is the challenge because you were high functioning
Right.
and you were in an environment, a parental environment that supported you and
Yep.
had the resources to kind of work you through. I went through the same thing. My dad's a dentist, and I mean, of
Right.
course, he had no way of knowing. But I look back, and my parents know I was a stomach sleeper. I sucked my thumb. My pillow had drool on it,
Oh yeah.
and there are pictures to this day, family pictures. I had that major interlabial gap, and then I went through a growth spurt, and so there was a lot of self-correction. I always say the body wants to heal and is able to kind of get through. And this is what makes it challenging because it's confusing that you go through these different periods that the body may adjust and correct some of it. You still have subclinical symptoms, but no one's connected it. But it's only till you go back in retrospect. And that's what makes it difficult, right? I mean, you're going to look at somebody, what can be wrong? When you've made it, here you are, clinical professor, world-class clinician. Uh, it's something separate, right? That's, I think,
Right.
the emotional part of it. What could have
That's
been.
exactly so incredibly true. Anyway, at this point, I'm just grateful that I've made, and I had to make a decision to take care of myself, whatever it takes. So if that involves finding a sleep center that obtains the proper data for my provider, I'm doing it, whatever it takes, and just make it happen. Um, it's it's simple but not easy. It's not easy. I mean, having in my particular case, it was not a local sleep center, and it was 2 days, so there was a lot of testing going on, and it's outside of your comfort zone. I mean, to sleep in a different bed that isn't your normal comfortable bed, and to be in a place by yourself, it's a challenge. But never once did I falter. Never once did I think, "Oh, I got to get out of here."
Okay,
Um,
so let's explain why
hmm,
you went to this particular see, and which just speaks to part of the problem, right?
hmm,
That you can't go down the street. This is what we're trying to fix, right? We're trying to
correct.
make it so that it's easier to attain these services that
Right.
currently the motivated patient is willing to do. They'll go to the ends of the earth once they understand,
Yep.
like yourself. But explain why you had sleep studies before, you
Yeah.
had the diagnosis.
Yes.
Why did you go through this effort for this particular data?
Uh, because at the advice of my provider, sitting right next to me here, I I needed to obtain better data, more detailed information to allow the insurance window to open for a procedure that is highly likely to occur. So, basically MMA surgery, maximum mandibular advancement surgery, and by having a very detailed sleep study that did incorporate the use of an esophageal probe, then I could gather the data if it was scored as a 1A study, and we can talk about that in a future podcast. But basically,
It was more
I
sensitive.
yeah,
It was a more sensitive.
absolutely.
Right.
So as a patient to to have something inserted in your nose that obtains this data, is kind of scary at first, but actually it was pretty easy. I'm surprised. And I don't want to get into the details unless you want me to, but basically, I
Was it a big
figured
deal,
that
right?
no, it wasn't a big deal at all. I mean, it just sounded kind of scary, but it actually was just totally easy. It was more, the most difficult thing was I was hungry, and I should have brought some snacks with me because there's a lot of breaks in throughout this 2 days. And that was the one thing I would recommend to my patients is bring yourself a little care package of energy bars or snacks or whatever, so that you don't have to call Uber to send food into the sleep center while you have these break times between the various studies that they do. Um,
I'd like to just kind of explain a little bit because it's really important.
yeah,
So the esophageal probe
right.
used to be the standard. So
Why did they
back
stop doing that?
in the 70s, well, I'll tell you, this kind of speaks to our allopathic system. So what happened is, Christian Guilleminault actually found in children, that's what his first one was in children. That's where he started looking at the flow limitation, and he was putting these probes in children.
Right,
And he was able to chart that flow limitation very, very sensitively way earlier than the actual apnea or hypopnea occurring. So he knew
right,
that was even before they would desaturate, that was an issue. And then that got changed to using a nasal cannula that detects that flow limitation to some extent, but yet less accurately. But it was much easier to do. And there were studies actually comparing the two and saying, hey, it's close enough. So, from the provider's point of view, what I've learned in talking to different sleep physicians to try to get them to do that routinely, because there are very few that do it,
hmm,
is that, oh, it's too invasive. They can't be bothered. First of all, they're not going to get paid because now the medical insurance is not likely to pay for that extra procedure. And even if they're not doing it, the lab tech, and they don't want the medical liability. So that's the number one thing. They're thinking that
hmm,
there's a medical liability if something goes wrong. They put it in wrong, and
yeah,
it's not. As you know, it's not that big a deal. So I think from the provider's point of view, they're trying to make it as easy as they can make it to get whatever diagnosis because the numbers are so big. Even if they just treat 10% of the population that are the low-hanging fruit, they can care less about the rest. They'll wait till they get sicker. So I think I want to make clear that's part of the problem is, and that's why you have to go to a different place because I couldn't refer you to anyone in our area that would do it.
right,
Not because they can't, but
right.
because they're not set up to do it.
That's so interesting. Yeah, um, I gotta, if physicians are listening to this, I would encourage you to keep an open mind and consider doing this. It was performed entirely by a sleep tech. She was incredibly competent. It took all of 8 seconds to place the probe into the right position. No pain whatsoever for the patient. Once the probe was placed, I didn't even notice it, and it was of zero consequence to my sleep. I didn't even remember I had it there. So and the data that is acquired is so valuable and so helpful. So
Yeah,
I'm just
I've had patients literally who've had 8, 10, 12 studies, honest to God, come in
wow,
with an Excel spreadsheet, looking
wow,
at the HI that's under 5 in all those studies. And then they have the sleep study and they find out they're severe. The apnea hypopnea has gone up to 35, where they were told it was
wow,
2
amazing.
routinely. But the other part of it too is the scoring of a 3% desaturation versus a 4%. So physiologically, they're night and day. We won't get into that now, but tell us a little bit about the nap the next day. So you had an overnight, and then you stayed overnight, and then there was another study done
Right,
during the
right.
day.
That was really interesting. So, in the morning of the after the first night, you wake up and there's a different team that'll come in. They kind of the the staff changes over, of course, and they explained everything to me ahead of time, so I kind of knew what was coming. But I took a series of naps. I think a total of 6 naps, 35 minutes each, with a break of about a half an hour between the naps. And that was because they were concerned about narcolepsy. It was a special test to take a look at this potential issue, to which I thought, oh, come on, narcolepsy. mean, my naive understanding of that was, oh, you just a person is walking down the street and then they fall asleep and collapse to the sidewalk. That's not narcolepsy. And so I was just fascinated by that. And I thought, oh, there's no way I'm going to be able to nap. This is crazy. They're going to tell me to go back to a nap. And I'm going to tell you, I napped like crazy. I napped without any problem at all. I was the model napper. And I, and that was all day.
As most males our age are.
What's the story with this? It was so interesting that I was able to do that, even though I was reading and awake. And they're like, "Okay, time for your next nap." I'm like, "Okay, yeah, sure." And then within 5 minutes, I'm boom napping again, and then almost frustrated that I'm being woken up after that. But I thought that was fascinating, and during that entire day, really, because it starts at like 6:30 in the morning and you go till about 4 o'clock, 4:30 in the afternoon. I was seen by multiple providers. Nurse practitioner comes in and does some additional, does essentially sort of an oral screening and did a few tests, and other health professionals occasionally taking your blood pressure and looking at your vitals, and then the tech coming circling back in again and again. So you can tell it's a serious effort, and it's the real deal. I mean, they take everything very quite seriously. All the data collection, all the I learned a lot about a high level protocols in a medical facility, how they speak to patients about the next step, explaining things, making sure that you're ready to go for the next procedure. Always ask you, do you have any questions? Do you have any questions? Every single time a provider left the room I was in, there was always that, well, great, I'm glad everything's okay. Do you have any further questions for me? You're okay? Great. Such a nice closure to that interaction with a provider. And I personally, as an educator, have seen very little of that in our own profession. The dentist finishes and says, well, that's it. You're in good shape. And they bust out of the room without even saying, now, do you have any questions for us? And I thought that alone was just really, really nice and educational.
Yeah, I think, it's important to understand this is part of the challenge is that most sleep labs are not set up um, to give this level of care. And you know how we always conclude with what was the lesson of the week? I want to conclude in a minute or two with some comments on exactly what you just stated. That's kind of wrong with healthcare per se, but just to kind of button this whole patient experience up, I think one of the things that I have noted, interestingly, you were saying that they were trying to rule out narcolepsy. I can't tell you how many of these patients were diagnosed with that and that I ended up treating, and quote unquote, that narcolepsy went away after they were properly treated. It's the
Right.
same thing with central sleep apneas, that they have X number of central apneas to go with the obstructive sleep apneas. And the literature actually will also say that the obstructive sleep apneas oftentimes lead to the central sleep apneas. And that if you are addressing the obstructive sleep apneas, you could still have some leftover central sleep apneas that have nothing to do with the tongue obstructing. And the
Mm-hmm.
reason for that is if you have decades of chronic intermittent hypoxia, there's certain segments of the brainstem and that relay to the brainstem and central nervous system that have been damaged beyond repair, that
Mm-hmm.
now the brain doesn't have the ability to correct an obstruction that ends up in a central sleep apnea. So why we want to deal with this earlier on. And yet we know that oftentimes they can heal and those quote unquote obstructive or the central apneas go away or greatly diminish. So again, it speaks to understanding how sick is the patient and what's the prognosis going to be. The earlier you catch it, the much better long-term prognosis. So,
Right. Right.
and without getting into all the details on these different parasomnia diagnoses, um, my experience has been the root of it is the flow limitation it begins with, and the damage and the level of damage really determines whether it's quote unquote narcolepsy or central apneas. But sounds like a great experience for you as someone who's teaching this and talking to your patients to be able to firsthand be able to do that. And that's also in the airway mini residency where we find a lot of docs going through and go, I'm next, I want to be treated. They start going through it themselves and they start really connecting some dots personally that empowers them to talk to their patients differently than if they're outside of it. And I think it's always good. Like
Right.
I will say, when I have you work on me, for example, you're my dentist, I'm sitting there and you're giving me a block. I'm always thinking in my mind, I'm on the other end of the needle, and you give it so compassionately where I feel very, very little of it, even though you might be in the grind of a day, you're taking the time in my patient experience, because one day that could be you. And I
Yeah.
think it's really important. One of the lessons of the day would be for the provider to put themselves in the patient's place,
Oh
to
yeah.
be compassionate and understand what they're going through. They're already going through enough. So with that, let's go ahead and do you have a um, thought of the week, if you will, that you want to share?
It's
Lesson.
actually, yeah, I mean, I was kind of thinking, oh, it would have something to do with this sleep study. But actually, my thought of the week or my lesson of the week is different. But it does, and you just, you might, the brain turned on at a moment about 3 minutes ago when you said something. One of your other patients is a dentist. He is a little older than me, but we're simpaticos. I mean, we're kind of in the same basic group, and he is sharing his experience with his treatment. And he's at the stage of he's a little ahead of me. He's at the stage of the MARPI, and he's expressing such joy in his improved symptoms. So much has helped him, and
Right.
I was like, wow, I'm looking forward to that for myself. I mean, right now I'm more in the diagnostic sort of data gathering part of the whole process, but he's in that treatment phase and it's early on and he's just loving it. And so we've been communing together back and forth, and I'm a little envious of where he's at right now, but it's also exciting because I'm going to get there too. I just know it. So
That's
uh,
great.
yeah, so I
Yeah,
mean, I think
that's
that should be
yeah.
encouraging for people. Is that
100%. And
yeah,
I think this is really what's exciting about doing, doing dentistry with an airway focus is that when you start doing these interventions, even though you're not to the end, you're like midstream or just in the beginning throes of the treatment, that you get these immediate return from the patient's experience qualitatively and also quantitatively because we measure it, that they're doing better. And
yeah,
then they become very motivated in saying, this is the first time that I'm actually having a tangible benefit to this treatment that I'm excited about. And anything that this provider tells me in the future, I'm going to do because you've won them over. So I have found
yeah,
that the full mouth rehab and all that restorative dentistry that we want to do, um, when you're doing it after the fact, that's a no-brainer. Well, you are the person that's going to do it because you're the first person that actually made me better. Whereas if you're trying to treatment plan that on the front end and
hmm
they're still sick, it's really more discretionary. So I think that's one thought. But it's ironic. This week I had one of my patients return back that I scheduled 2 weeks ago on a consult, and today or this week, I think it was on Monday, he told me about his experience, and he did already come in with a diagnosis of obstructive sleep apnea. Um, and I sent him to, because he had lost it had been many years ago. He didn't have the data, and we needed that. So I sent him to the local place, and I sent him to the local place because his diagnosis was already so severe that I
right,
didn't need to go all the way through and do what you did.
right,
We already knew that he had what I call low-hanging fruit.
right.
But when he came back this week, his main concern after all was said and done, he said, I have to tell you, that was one of the worst experiences I had.
Hmm.
I went in there and they didn't ask me how I was doing. They were wiring me up. And I was telling him, well, what do you do if I'm stop my breathing? And said, don't worry about it, we're here. And he was uncomfortable with it. And I'm actually, and he asked me to circle back. So I'm actually going to go back to that sleep lab. I'm going to talk to the manager. I'm actually going to talk to the sleep physician who I know who would be mortified about that. And
Right.
to say, look, you need to really treat our patients better and give them the experiences they understand of what's going on and that they're reassured. Everything that you explained. And so I think that's the lesson of the week. It could be that, or it could be that you're prepping for um, uh, a all ceramic crown. I think it really behooves the provider to explain before we're going to anesthetize. I'm going to use a rubber dam. I'm going to explain that. I'm going to do this. You're going to leave with a temporary. And then when you're done, any questions? Joni is going to give you post-procedure instructions. But I think that us taking the time to do that, that's I guess, the lesson of the week is to not get so caught up in our own little world of busyness, procedure after procedure, and obviate that important human touch. We could be high tech, but let's not also be low touch. I think we also need to be high touch. So I think that's the
Well
lesson of
said.
the week. Does that
Well
make sense?
said. Makes sense, and it was well said. Thank you, Mark.
Thank you.
I agree 100%.
Well, thanks for sharing your experience, Rich, and look forward to our next podcast.
You
Have
too,
a
Mark.
great rest of your week. All
You
right,
too,
take care.
buddy. All
I'll
right,
see you.
thanks.
All
See
right,
you.
thanks. Bye.